How's everybody doing? All ready? That's it, exam 5. It's all done, all finished. All right. If you go to UCF, if you go to ucfstudyunion.wordpress.com, all of my review materials are on there. ucfstudyunion.wordpress.com. Okay, all of my materials are on there. So what I have pulled up right now is my study guide for this section. I also have a practice exam on that site. And just today I posted clinical questions as well. So I made about something around like 5 or 6 clinical questions, and I posted it in the website as well. So that's all on there right now. What I'm going to do is go through like a review of just the material that you're going through. I'll kind of use this loosely, but I'm going to kind of take my own liberties with it too. And then we'll do like a couple of questions of practice exam to make sure you guys got it, and then we'll finish up with clinical questions. Okay? I do have some stuff to hand out. These are surveys I'm going to need you guys to fill out like by the end of the session. So just hand them back to me or leave them at the end of the session if you can pass these down. Thank you. Would you pass these down for me? Hello. One. There you go. Thanks. This one's over. Thank you. Thanks. Mm-hmm. Am I ready? It's going to be a long 2 hour. We're going to make it work, though. Don't worry. Can you pass those down, please, for me? Thanks. Thank you. Anybody have any extras? Yeah. Okay. All right. So most of this exam is going to be on the endocrine system, just general endocrine system, and then you also had the one PowerPoint about reproduction later on. So we're going to focus mainly on just main endocrine system, and then we'll hit some of the reproduction a little bit later. Endocrine system, remember, is a system of hormones. Hormones circulate in the blood and bind to receptors. Depending on the type of hormone, it can be a cell surface receptor or it can be a nuclear receptor. If it is a steroid hormone, it will bind to nuclear receptors. If it is a peptide hormone, it will bind to cell surface receptors. Okay? You learned about 4 different types of cell surface receptors. There were like 4 different types of slides. One was cytokine receptors, GPCRs, tyrosine kinase, and what was the other one you guys learned about? Ligand gated, something like that, right? So all of that information is in your slides. It's just one of those things. Just read those, whatever, 3 or 4 slides, and just find similarities, pick out similarities between them and compare them. All right, that's just about memorization. Make like little charts or whatever for you guys to do. But remember that all of those are cell surface receptors, and they're binding to peptide hormones. All right, so just remember that. Remember, steroid hormones are able to get through the cell membrane. So once they get through the cell membrane, they can then bind to nuclear receptors. That's why they're able to do that. Okay? Thyroid hormones are another kind of weird one. Even though thyroid hormones are not steroid hormones, they're still able to get through the cell membrane, and therefore they're still able to bind to nuclear receptors. Okay? So they're still able to bind to nuclear receptors even though they are not steroid hormones. That's your exception. The thyroid hormones, I'm not talking about TSH. I'm talking about the hormones that come from the thyroid gland, T3 and T4. Okay? We'll talk about those later as well. All right. Okay, let's have some fun now. Yes. It works. All right. So we're going to talk about the hypothalamus and pituitary gland and how they're connected. That's your hypothalamus. That's your pituitary gland, anterior, posterior. Okay? This is not anatomically correct. This is not what it looks like in your brain, but it's a good representation of what's happening. The hypothalamus is connected to the anterior pituitary gland via bloodstream. Okay, so this is a blood vessel. The hypothalamus is connected to the posterior pituitary gland by nervous tissue. The anterior pituitary gland secretes 6 hormones. If you don't remember the 6 hormones, you should. You can use the acronym. Some people use flat pig. I use flat pug. I like pugs. I don't know. Someone always says they're adorable in an ugly kind of way, or something like that. I don't know. I like them. Anyway. So this acronym, you can kind of see where this is going. So this is FSH, LH, ACTH, TSH, prolactin. The U doesn't mean anything. And then G is growth hormone. Okay? So you can always use the acronym flat pug or flat pig if you ever get confused on what comes from the anterior pituitary gland. All right. So we're going to talk about these a little bit in order. Growth hormone is kind of self-explanatory. It helps you grow. So yeah, that's why it's called growth hormone. I want to talk more about ACTH, TSH. We'll talk a little bit more about FSH and LH later and prolactin. But right now, let's go into ACTH and TSH and talk about how that works. And then also, just to remember, from the posterior pituitary gland, we have oxytocin, And what's the other one, guys? Anybody know? ADH. Good. All right. All right. Oxytocin and ADH. ADH is antidiuretic hormone. You learned about that. I think like Unit 1 first introduced it, and then the kidney section also. All right. So let's talk about ACTH first. This is your adrenal gland. This is the cortex, this is the medulla. Okay? So the outer portion is the cortex. The adrenal cortex secretes 3 hormones: aldosterone, cortisol, androgen. Okay? And these hormones are secreted upon ACTH stimulation. Okay, so when ACTH binds to the adrenal cortex, it releases these 3 hormones. All right? Androgen is not as important for us. The main things we talk about when we talk about disease is going to be aldosterone and cortisol. Okay. Anybody remember what aldosterone does? Yeah. Absorption of what in the nephron? Sodium, and what else does it do? What other ion does it move? Potassium, good. So aldosterone helps us to reabsorb sodium from what would be urine and put it back in the blood. So aldosterone increases our blood sodium. And it also makes us secrete potassium, so it decreases our blood potassium. Okay? Overall, what does this serve to do? Why would we want to secrete aldosterone? In what conditions? Low blood, not necessarily low blood volume, low blood pressure. So specifically, we're going to secrete that when we have low blood pressure, because these are going to serve to increase our blood pressure. Okay? So aldosterone is sensitive to blood pressure. Okay? Aldosterone is sensitive to blood pressure. So in response to low blood pressure, we secrete aldosterone. What about cortisol? Cortisol has a lot of functions. Cortisol increases your blood sugar. That's one thing it'll do. So it will increase sugar. Okay? What are some ways that we increase sugar in the blood? What are some ways that we can do that? What are some processes that we know of? Glycolysis. Will glycolysis increase sugar in the blood? No. What will? Okay, glycogenolysis or glycogenolysis, right? So that will definitely do it. So we break down glycogen and release glucose. So that's one way cortisol can work to increase our blood glucose level. What's another way possibly that it can work? Gluconeogenesis, very good. Gluconeogenesis means we're making new glucose out of non-carbohydrate sources, right? So we're breaking down proteins or we're breaking down fats, etc., to make new glucose. So cortisol will stimulate gluconeogenesis and glycogenolysis, okay, to make more glucose in the blood. Cortisol also increases our blood pressure. All right, it increases our blood pressure by increasing something called total peripheral resistance. Okay? So it increases total peripheral resistance. That's basically, just think of it as like increasing the resistance in like peripheral blood vessels and causes an overall increase in your blood pressure. All right, so just know that it increases blood pressure by increasing TPR. Can you guys hear me okay in the back? Yeah? You're good? Okay, cool. All right. Cortisol also has some other weird side effects. It actually it decreases your skin strength, so it makes your skin weaker. And it increases your appetite as well. Androgen is just a sex hormone. I'm not going to write that here right now, but androgen is a sex hormone. And it's kind of can serve as a precursor to testosterone. And we'll talk about it a little bit more when we get to reproduction. Okay? So now that we know what ACTH does and how this works, there's a very big disease that you guys need to know. Two very big ones related to the adrenal gland. What are they called? What? Okay, that's related to the adrenal medulla, right? But what are the two diseases that are related to the adrenal cortex? Addison's and what else? Cushing's, very good. All right. Okay, this is how that works. So this is at the hypothalamic level. This is at the pituitary level. And this is at the actual adrenal cortex. All right. In Cushing syndrome. Cushing syndrome, we have two types, primary and secondary, and that's going to be determined by where the actual issue is. So if we have a primary disease, where's the issue? In the gland or in the pituitary gland? Cortex or pituitary gland? Cortex, good. Cushing syndrome is defined. It is defined by increased levels of aldosterone, increased levels of cortisol, and increased levels of androgen. Mainly cortisol is the issue, but for our purposes, all three is what we're focusing on. In a primary situation of Cushing syndrome, normally what our body would want to do, once it senses we have increased levels of these hormones, is we'll get feedback to the hypothalamus. The hypothalamus will say, whoa, we should stop secreting these hormones, so let's decrease CRH. A decrease in CRH would lead us to decrease ACTH from the pituitary gland. But we have primary Cushing syndrome, so our adrenal gland, our adrenal cortex is jacked. And our adrenal cortex does not care about what the pituitary gland is telling it to do. So it's going to continue to secrete aldosterone, cortisol, and androgen in primary Cushing's. What happened? There we go. Okay, does that make sense? So because there's an issue right here, that's going to prevent the adrenal cortex from receiving the signal to stop secreting its hormones. So that could be, I know she mentions a bunch of different causes for it, like tumor, autoimmune, bacterial, things like that, infections. That's what's causing Cushing syndrome, primary Cushing syndrome. Any questions about primary Cushing syndrome? Yeah. With any primary disease, the issue is going to be in the gland that is actually secreting the effector hormones. So in this case, our problem is because of increased cortisol and aldosterone. So in a primary situation, The issue will be in the gland secreting aldosterone and cortisol, which is the adrenal cortex in this case. Any other questions? Okay. In a secondary disease or secondary Cushing syndrome, in this secondary disease, we have to have high aldosterone, high cortisol, and high androgen. The issue in a secondary case is always going to be upstairs in the brain somewhere. So it's going to be either the hypothalamus or pituitary gland. Okay, I'm going to say it's in the pituitary gland, and that's how I would suggest you think of it as well, and you'll see why in a second. When there's an issue, again, we're going to have feedback. Hypothalamus will say, okay, let's decrease CRH. But now we have a problem here in our pituitary gland. Our pituitary gland wants to continue secreting ACTH. So we'll still have high ACTH in this case. Does that make sense? The high ACTH goes to the adrenal cortex and makes it secrete its 3 hormones. So in a primary case of Cushing syndrome, we would have low ACTH. But in a secondary case of Cushing syndrome, we'd have high ACTH because the problem is in the pituitary gland in this case. Any questions about that? Okay. Even if the case were in the hypothalamus and you had high CRH, ACTH would still be high in that case. So either way, you're going to have high ACTH in a secondary Cushing syndrome disease. Okay? The symptoms of Cushing syndrome are what? What are some symptoms that you can just sort of automatically off the bat tell? High blood pressure for sure. What else? What was it? Infertility because of the androgen. Yeah, like I said, we'll talk about that more in the reproductive, but that could definitely be an issue. Yeah? Yes, you could have some awkward body hair there if you're a woman specifically. Good. Okay, what else? I heard hyperglycemia somewhere, right? So which one causes that one? Cortisol, right? So the cortisol is going to have hyperglycemia or cause us to have hyperglycemia. We also have some weird symptoms that are not necessarily right away evident. Yeah? Good, yeah. So one of the ways we're increasing blood pressure is aldosterone, and aldosterone causes increased sodium, so that's hypernatremia. Yeah, excellent. So you would definitely have hypernatremia, and you would definitely have hypokalemia, right? So low potassium, hypokalemia. Yeah, very good. There are also some weird symptoms. There's something called moon face. Okay, so that means like their face literally gets round. There's like fat deposition around the neck and the face. Remember cortisol. Cortisol stimulates gluconeogenesis. And one of the things that gluconeogenesis does is it'll break down proteins for new glucose, right? So it will break down muscle tissue in order to make glucose. So we have thinning limbs in Cushing syndrome as well, both primary and secondary. And then something called truncal fat deposition. So it's putting the fat in the center of your body. So that means chest, that means stomach. They also have something called a buffalo hump as well, so they can have fat deposition back here. All of those things are indicative of Cushing syndrome. Okay? Any questions about Cushing syndrome? Yes? Primary and secondary? No. No. There's no difference in the symptoms for Cushing syndrome between primary and secondary. The only difference is ACTH high or low? Okay? All right. Addison's disease you can think of as essentially the opposite of Cushing syndrome. You can think of this essentially as the opposite of Cushing syndrome. Addison's disease is specifically low aldosterone, low cortisol, low androgen. In a primary case, is the problem in the cortex or pituitary gland? Cortex, good. All right, problem is in the cortex, so what does that mean? We're going to have feedback. Low hormones here will tell the hypothalamus, hey, beef up the CRH. CRH gets beefed up, that tells the pituitary gland, hey, beef up the ACTH. Great, we're going to make more hormones, right? No, cortex don't like that. Cortex has problems because it's Addison's disease primary. Issues right here. So we're going to have decreased aldosterone, cortisol, and androgen still. Okay, that's the issue with primary Addison's disease. All right. One of the other weird things that I'll just mention right now, your pituitary gland also has another hormone that she says comes from the intermediate lobe. Do you guys remember this? It's called POMC, or pro-opiomelanocortin. All right. POMC serves as a precursor to ACTH. So when we want to increase ACTH, we will be increasing POMC. Okay? POMC also serves as a precursor to MSH, or melanocyte stimulating hormone. You guys remember this? Is this ringing a bell? Okay. This is going to stimulate melanocytes to produce melanin. And that's going to cause one of my favorite symptoms to say, hyperpigmentation, right? Hyperpigmentation. Hyperpigmentation. Okay. Hyperpigmentation. So, primary Addison's disease, we have hyperpigmentation. This is not all over your body. It is not like you all of a sudden become darker like you went to Miami and got a tan. This means that you have hyperpigmentation weirdly, like in the palms, face, things like that, okay? So that's primary Addison's disease. Hyperpigmentation is associated with primary Addison's disease, all right? All right. Any questions? Yeah. In primary Cushing syndrome, because the POMC is stimulated by the hypothalamus, so the hypothalamus would have to stimulate POMC from the pituitary gland, and that doesn't happen in Cushing syndrome. Okay? That'll happen in this case because the hypothalamus is sensing low hormones and telling the pituitary gland to beef up POMC and ACTH. Does that make sense? Yeah. Good question, though. All right. Secondary Addison's disease. And I'll talk about the symptoms of this in a second also, but so, again, we always, in Addison's disease, have low aldosterone, low cortisol, low androgen. Sometimes this is called adrenal cortical insufficiency. Okay, it doesn't always have to be called Addison's disease. So you might want to write that in your notes or underline where you see that in PowerPoints and stuff. This can also be called adrenocortical insufficiency. Okay? Adrenocortical insufficiency. Don't get tripped up with that just in case you see that. All right? So again, this is a secondary case, so the problem is in the, let's say, pituitary gland. We're going to have feedback to the hypothalamus. Hypothalamus will beef up CRH again, but the problem is right here in the pituitary gland, so the pituitary gland is not listening, and we still have decreased ACTH. And that decreased ACTH is going to prevent more aldosterone, cortisol, or androgen from being produced from the adrenal cortex. Okay? So that's the difference. In secondary cases, you can kind of think of it as the pituitary arrow and these hormone arrows are going the same direction all the time. And in primary, they're opposite. Yeah? Is that a question? So could the problem be in the hypothalamus as well, or just the pituitary? It could be in the hypothalamus. I'm not saying it can't be. But the thing is, whenever you get a question or anything like that, they're going to tell you probably if they have what their ACTH levels are. And whether the problem, as long as it's secondary, it doesn't matter if the problem is in the hypothalamus or the pituitary gland, ACTH will always be low for secondary Addison's disease. Does that make sense? So if you see low ACTH, that's telling you it's secondary Addison's disease in this case. Does that make sense? Good? Cool. Any other questions? What primary was? Yeah, so primary, the problem was in the actual adrenal cortex. So you would have high ACTH because the pituitary gland is fine, but the cortex would not be secreting those hormones properly. So you would have, the only difference is that ACTH arrow would be flipped up. Okay? Yep. Okay, Addison's disease, you can kind of tell what the symptoms are going to be, right? Low aldosterone means we have low blood pressure or hypotension. So that means hyponatremia for low sodium, hyperkalemia because we're not secreting potassium, right? We might have hypoglycemia because of cortisol. Okay. Low androgen, probably not an issue. Again, it's not that big of an issue unless possibly in females, but it's not as big of a deal because the cortex doesn't secrete as much androgen. Okay? Remember, secondary does not have hyperpigmentation, primary does. So that's your big differential diagnosis. All right. Any questions about the adrenal cortex before we move on? Okay. All right, let's switch over to one of my favorite glands, the good old thyroid. This is the same thing. The top one is hypothalamus, middle is pituitary gland, bottom is from the gland itself, from the thyroid gland itself. Okay. So T3 and T4, again, were hormones that are able to bind to nuclear receptors, okay? And their precursor is iodine. So the precursor to T3 and T4 is iodine, right? So I'm going to actually do a scratch flow chart right here. So when TSH binds to the cell, it turns on what's called an iodide pump, okay? Iodide enters the cell. So it converts to I2 by peroxidase. This is iodine now by peroxidase. So it gets converted to iodine by an enzyme called peroxidase. That's called the oxidation step of thyroid hormone synthesis. Organification step happens when the iodine actually gets coupled with tyrosine, which is an amino acid. And then essentially think of it, if the tyrosine picks up one iodine, it'll be MIT, or monoiodotyrosine. If it picks up two iodine, it'll be diiodotyrosine. Okay? If you add mono to di, that's 1 plus 2, that makes 3. So that's T3. If you add di to di, that's 2 plus 2, which is 4, so that's T4. Okay? Does that make sense? Everybody okay with that? All right. So if you ever get confused, you can always just pull out that simple math. 2 plus 2, T4. Good? Cool. All right. These are not active. So MIT and DIT are not active on their own. They become active when they couple with each other. Okay. So think of the thyroid hormones as like your sympathetic nervous system. They're going to do a lot of the same things that your sympathetic nervous system does. They'll increase heart rate, increase blood pressure, things like that. Anxiety. So let's talk about different types of diseases and things like that we have with the thyroid gland. You learn about hyperthyroidism and hypothyroidism. In hyperthyroidism, that means we have high T3 and T4. Okay? Primary hyper. Thyroid. So in a primary situation, high T3 and T4 will give feedback to the hypothalamus. Hypothalamus will say, let's lower TRH, or thyroid releasing hormone. Low TRH will signal the pituitary gland to decrease TSH, or thyroid stimulating hormone. But again, our thyroid gland is jacked. So there's a problem right here, and it wants to continue secreting T3 and T4. So maybe there's a tumor of the thyroid gland, inflammation, different types of autoimmune diseases that you learn about. But that's just your general primary hyperthyroidism. Again, these are all going to look very similar. So this looks very similar to what we did with ACTH, right? Notice again, primary situation, these arrows are flipped. TSH is down, T3, T4 is up. In a secondary case, everybody okay with that so far? Good, yeah? I will take your silence as a yes. So, in a secondary case, secondary case, again, we have high T3 and T4, that is hyperthyroidism. Feedback will lower TRH, but the problem is in the pituitary gland, let's say for this case. If it were, regardless of whether it's in the hypothalamus or the pituitary gland, TSH will be high. And TSH is what you can test. So in a question, let's just say, you would be given probably a TSH level, and that would be what you would be able to make your determination on as to whether it's primary or secondary. So in this case, high TSH and high T3 and T4 because of the problems in the pituitary gland. The thyroid gland doesn't know any better. It just keeps secreting based on the TSH input. Okay? Any questions about that? Symptoms are the same. So it's going to be the symptoms of high thyroid hormones. So you'll have anxiety, the high blood pressure. She also mentions, basically, it's increasing your metabolic rate. Okay? So that's weight loss, right? Increasing metabolic rate, weight loss. You'll also feel warm. Yeah, you also feel warm. So you'll feel hot, anxious. I think she uses the example like talking a lot or something like that. They talk a lot. That's hyperthyroidism. You could probably guess this based on all the primary stuff and secondary stuff we've done so far, but this is hypothyroidism now. Low T3 and T4 is hypothyroidism. That's going to tell hypothalamus, okay, secrete TRH. Pituitary gland says, okay, I'll secrete TSH, but there's a problem in your thyroid gland because this is a primary problem. Okay? So primary means the problem's in the gland. That's primary hypothyroidism. Of course, this is secondary. That's where the problem here is in, I'll say, the pituitary gland. Can you guys see that okay? So problems in the pituitary gland. So even though the hypothalamus is increasing TRH, pituitary gland doesn't listen and doesn't secrete more TSH. Okay? So we still have the low T3 and T4. All right. There are a couple of specific things I want you guys to remember about the thyroid gland, specific diseases that are very important. There are two autoimmune diseases. We have Graves, and we have Hashimoto's. Okay. So Graves' disease is normally is hyperthyroidism. Excuse me. Graves' disease is hyperthyroidism. Hashimoto's is normally hypothyroidism, but could possibly be hyperthyroidism. But it's normally hypo. These are both autoimmune diseases. Okay? They're both autoimmune diseases. In Graves' disease, because of the autoantibodies can accumulate behind our eye, cause inflammation behind our eye, and cause our eyes to bulge out. So they have bulging eyes. Along with, of course, all of the symptoms for hyperthyroidism. Okay? So along with all of the symptoms for hyperthyroidism, loss of weight, anxiety, hypertension, etc. Hashimoto's, again, this is an antibody disorder, or autoimmune disorder, they're going to have all the symptoms of low T3 and T4. Okay? So that's your weight gain, lower metabolic rate, lower heart rate, things like that. So essentially, think of hypothyroidism as like parasympathetic and hyperthyroidism as sympathetic, if that helps you. Okay? Anybody have any questions about that? Yeah. So it's an autoimmune disorder, which means that it's mediated by antibodies, by autoantibodies. So yeah, you'd still have higher antibodies that are attacking yourself, but it has a different effect. Hashimoto's is going to have low T3 and T4 usually, and Graves' disease is going to have high T3 and T4. Okay? Any other questions? Yeah? So you would look for antibodies, yeah. So you would diagnose, you can do a blood test. So if you take a blood test, centrifuge the blood, and take the serum part, like the upper part, you can test for antibodies or autoantibodies, okay? So if you have let's just say you have a test question that says something like giving you all of the symptoms for hypothyroidism, and they also say that the patient has high protein in the blood or high antibodies in the blood, that can kind of tip you off, okay, this is autoimmune, this is probably Hashimoto's. All right. Okay. Since I'm in this, any last questions about the thyroid gland? All right. Since I'm in that region, I'll talk about the parathyroid gland. Parathyroid gland is very specific. It has essentially one function that you guys learn about, and that is to increase calcium. So the parathyroid gland secretes PTH, or parathyroid hormone, and that's going to increase calcium, but it's going to increase calcium in a couple of different ways. Okay, just follow me with this flow chart. Can you guys read that? Kind of. Okay. PTH is able to increase calcium in 3 different ways. One of them is by activating vitamin D. So PTH will act on the kidney. The kidney is where vitamin D activation occurs. Okay? You guys remember the name for active vitamin D? The chemical name? 125, what else? Yeah. Yeah, okay. Yeah. 125 dihydroxycholecalciferol. Okay, I always joke I'm going to name my firstborn son that. Little dihy. 125 dihydroxycholecalciferol. 125, 1,25. All right, inactive vitamin D is just 25 hydroxycholecalciferol. Active is 1,25. You add the 1 in there. All right, okay, it's number 1. It's the active one, right? 125 dihydroxycholecalciferol. Okay. It increases calcium absorption, which occurs in the small intestine. So it binds to the small intestine and causes increased absorption of calcium. Okay. And it also breaks down bone. So in our bones, we have calcium. Okay. So it will activate systems that apparently activates osteoclast. So it activates systems that break down bone. When you break down the bone, you're essentially releasing the calcium out of the bone and it goes into the blood. Okay, so those are the three ways it does it, yeah. Yes. So vitamin D is activated in the kidneys. Yeah, so PTH, essentially it increases an enzyme that makes that conversion. Yeah, calcium absorption is in the intestines. Remember, nutrients are absorbed in the intestines. All right, so calcium absorption happens in the intestines, small intestines specifically. Yeah. Any questions about PTH? If I have a whole bunch of PTH and it's giving me a whole bunch of calcium, is that a good thing? If I'm over-secreting PTH, what can happen? Osteoporosis, because I'm breaking down too much bone, right? It's making my bones all porous and stuff. What else can happen? What? Muscle spasms due to what? Excess calcium, yeah. So calcium will essentially overstimulate nerves and muscles, and so they'll spasm. Any questions about that? Good, good? All right. Let me do it on time. Talk about thyroid gland, adrenal gland, PTH. Okay. All right. What about what? Sure. So if you have a deficiency of PTH, what will happen? Muscle spasms. Well, okay, so why? Decreased calcium. Yeah, thank you for that. If you have a decrease of calcium, that can also lead to muscle spasms. Okay, so either an increase, either hyper or hypocalcemia can lead to muscle spasms. Okay, so low PTH would also cause muscle spasms as well. All right. Yeah, thanks for that question. Thanks for that. You guys ready to talk about everybody's favorite gland? Pancreas? All right. All right, we have 3 different hormones that we talk about that come from the pancreas. Glucagon, insulin, somatostatin. I always use the acronym, even when I was in this class. I used the acronym AGBIDS. These are alpha cells, glucagon. Beta cells, insulin. Delta cells, somatostatin. Okay, if that helps you, there you go. Glucagon comes from alpha cells, insulin comes from beta cells, somatostatin comes from delta cells. All of the pancreas. Glucagon will serve to increase your blood glucose. Okay? It increases your blood glucose. We talked about some different ways that glucose can be increased earlier, and those rules still apply. Glucagon, actually I can write it. So glucagon will stimulate glycogenolysis and will stimulate gluconeogenesis. Okay? So it'll stimulate each of those, glycogenolysis and gluconeogenesis. Some other things just by extension of this. Increases lipolysis. Lipolysis is the breakdown of fats. So that's just a part of gluconeogenesis. Does that make sense? We're breaking down fats to make glucose. Increased proteolysis, breaking down proteins to make glucose, still part of gluconeogenesis. Okay. Insulin is essentially going to be opposite of this. All right? So insulin wants to decrease your blood sugar. Insulin, when it binds to the cell, it increases GLUT4 production. Very simply, GLUT4 is a doorway. It gets put into the cell membrane and allows glucose to come into the cell. That's all that happens. Glucose that is in the blood will just come into your cell through the GLUT4 protein, or GLUT transporter. Okay? So that's why it's increasing GLUT4 production. Insulin is going to increase not glycogenolysis, but glycogenesis, because we're making glycogen. We're putting the glucose into the cell to make glycogen. It's also going to stimulate glycolysis, because we're putting glucose into the cell and we're able to use it for energy. That's glycolysis. Okay. So just some things to remember. Don't get confused with all the glyco and gluco and stuff. Just understand what they are. The suffixes help. Glycogenesis, making glycogen, right? Glycolysis, breaking down glucose. Okay? Insulin essentially works to inhibit the function of glucagon. Glucagon works to inhibit the function of insulin. Yeah?
I'm confused on how insulin, it produces glycogenesis, like to reduce the amount of glucose.
Yes.
But if it does glycolysis, wouldn't that break down glycogen into glucose?
No. Glycolysis is the breakdown of glucose into pyruvate. So it's you're breaking down glucose, but that's happening in the cell. So glucose comes into the cell, and essentially the fate of glucose can go two ways. It can be either glycogen or glycolysis. Does that make sense? So once glucose is in the cell, one of two pathways are going to happen. Any other questions? Okay. Okay. So let's talk about diabetes. Diabetes mellitus, specifically, is a lack of insulin function. That's what I'm going to leave it at, a lack of insulin function, okay? Diabetes mellitus has two different types. We have type 1 and type 2. So we'll talk about type 1 first. Diabetes type 1 is another one of your, well, someone tell me what is diabetes type 1? Who knows? What? Breakdown of beta cells? Okay, what type of disease broadly is it? Autoimmune, good, all right. So it's an autoimmune disease that breaks down beta cells. Obviously, if we're breaking down beta cells, we're not secreting as much insulin, right? So this is an autoimmune disease. And it is a problem in the actual beta cell. Okay, so it is a literal lack of insulin. Insulin, okay. This will often occur earlier in life. So in fact, they used to call this like childhood diabetes or adolescent diabetes because it occurs earlier in life because it's an autoimmune disease. Type 2 diabetes diabetes mellitus. Okay. This is not necessarily a lack of insulin. There's nothing wrong in the beta cell. Where is something wrong? Receptor. Okay, there's something wrong at the insulin receptors. Okay. So this is a receptor problem. If we're looking at diabetes mellitus type 1 and type 2, which one do you think insulin, synthetic insulin, would be a better treatment for, type 1 or type 2? Type 1, why? Yeah, because so the receptors are able to bind to insulin in type 1, right? Receptors are able to bind to insulin. So insulin would still work. It would work in type 1. Type 2, it's not going to have as much of an effect because you have so many insulin receptors that are already damaged. The new insulin is not going to make as much of an effect in type 2. Okay? Everybody clear on that? Cool. Okay. 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 With regard to reproduction, somatostatin, by the way, that other hormone, I didn't talk about it as much because it literally just affects glucagon and insulin. Okay, so it just inhibits the secretion of glucagon or insulin. That's what it does, somatostatin. With regard to reproduction, there are a couple of flow charts that I'm going to make, and then just talk a little bit about it, but there's only one PowerPoint slide on it, obviously, so. So spermatogenesis is the formation of sperm or spermatids. It winds up as spermatids. Okay? So this is just a flow chart for spermatogenesis. So you have spermatogonia, which are dormant cells. They're like the precursor cells. And these are present in the seminiferous tubules. Okay? After some mitotic divisions of these spermatogonia, they turn into primary spermatocytes. Okay. All right. Notice this right here. Okay? Primary spermatocytes undergo multiple divisions. One of them is meiosis, a meiosis division. It forms, oh. You guys got to tell me when I do that. All right. Secondary spermatocytes are haploid cells. So this is after meiosis of primary spermatocytes. It forms secondary spermatocytes that are haploid. And there are two of those. So per primary spermatocyte, there are two secondary spermatocytes. Okay. These two secondary spermatocytes undergo another division, and they form 4 haploid spermatids. Okay? So that's spermatogenesis. Please pay attention to where the diploid is, where the haploid is, what the numbers are for these, yeah? This is occurring in the, I believe so, yes. Let me see if I can, just to make sure. Yeah, I believe so. Okay. Okay. And I also want to do a flow chart for, where is it? Oogenesis. Okay. So this is essentially oogenesis. And again, you're going to notice a lot of similarities between this and spermatogenesis. Just recognize that the oogonium are dividing into primary oocytes before birth. Okay? After birth, there is no more formation of primary oocytes. During puberty, we have the formation of this Zona Pellucida. The Zona Pellucida is just essentially a sort of like one layer of cells that forms around the oocyte. The secondary oocytes, they're haploid, so there's a meiotic division that occurs, and the cells increase. So there are like, instead of one layer of cells around it, there are two layers of cells that are around the secondary oocytes. And those are haploid, again, because it's a meiotic division. Couple of other things I just want to mention. Please make sure that you study the menstrual cycle, okay? I'm going to be totally honest. The menstrual cycle was, no offense, probably my least favorite part to learn. That's just me. I did not like it as much. I don't know if it's because I don't relate to it. I'm not really sure. I don't know. I don't know why it is. When I took endocrinology, when I took this class, it's just like I don't know what it is. But I do know this. You have essentially like 3 phases of the menstrual cycle. I do know that. I know that there's a follicular phase. I know that there's normally a line here that says ovulation. And then I know that there's a luteal phase. That I do know. I do know also that FSH is high during the follicular phase, as well as estrogen. This is essentially preparing the follicle for ovulation, so for the movement of the oocyte, essentially. That's what it's doing. I also do know that ovulation is sparked by a peak in LH. Okay, and it happens right before ovulation. So this peak in LH happens right before ovulation occurs. Okay? The luteal phase is when we're sort of preparing the uterus to receive the egg. Okay, so I think Dr. Ohangari normally says like we're making it nice and comfortable for the egg or something like that. Do you guys remember that? Right? And which hormone does that? What was that? Okay, but we have estrogen and what's the other one? Okay, there we go. All right. All right. Yeah. That's what I've been able to get out of physiology and endocrinology over the last year about the female reproductive system. I've gotten that down. Like this I know. Other things to just remember. FSH and LH come from the anterior pituitary gland. They are also subject to feedback. So for example, let's say that we have a female who has high androgen levels. androgen is going to work essentially as a feedback, and it will decrease the levels of FSH and LH. Okay? Obviously, if we have low levels of FSH and LH, that is going to prevent this menstrual cycle from occurring, and we'll have something called like amenorrhea, if you heard that or saw that in your slides, lack of a menstrual cycle. Prolactin also inhibits FSH and LH. All right? So this is why prolactin levels in non-pregnant females are normally low, so they can have menstruation. However, prolactin in pregnant females gets higher because they do not have menstruation. They cannot have menstruation. But prolactin also is needed for help of production of milk from the mammary glands. That's production of milk from the mammary glands. Okay? So high prolactin will mean amenorrhea as well, or a lack of a menstrual cycle as well. Okay. Another thing I want to mention, just know where these hormones are secreted from. So like testosterone, for example. You guys remember what cells secrete testosterone? I heard, someone said Leydig. I could swear I heard Leydig. You said it? Yeah, Leydig cells. So testosterone is secreted from Leydig cells of the testes. Okay? And then we also have Sertoli cells that secrete inhibin. So I just want you guys to remember that as well. Okay. Yeah. FSH and LH. Yep. Yes, so prolactin decreases those hormones, specifically decreases them. If you guys are wondering why I'm facing this way when I'm doing this, it's because my monitor up here is not working, so I have to like do this. It's fun. Last tutoring session ever, and that guy happens. That's awesome. All right. See if I remember how to do this. All right, guys. We're going to play Kahoot. See how this works. Okay. Go to kahoot.it. Go to kahoot.it and enter that game pin. All right, so whatever phone, laptop you have, and just make your, nothing obscene. Don't put any, just a nickname. The questions that are going to be on this are going to be very similar to most of the ones I have on my practice exam. I just had to change them to fit this mode, this Kahoot. All right, I'll give you guys a couple more minutes. UCF sucks. I'm graduating, don't tell me that, my goodness. Please don't tell me that. I got to get into med school, don't tell me. Oh God, we're getting political, please no. Goodness sakes. Who's not the winner? Who put not the winner? What kind of low self-esteem does that person have? Who did that? See, and then Spice Daddy has way too much self-esteem. I don't know what's going on with Spice Daddy. That's on another level, I don't know. Okay. Has anybody not signed in who wants to sign in? One person back there. Anybody else? Did you do it? Was that you? Is everybody signed in who wants to sign in? Okay. All right, so we're going to start. The first question is just like a test question, just to make sure everything's working. Randomize my questions. See what we got. I think we had 67 people sign in, so we should have like 67 answers. Eight seconds. So that's the false one. It's not directly put into MIT and DIT by peroxidase, right? It has to go through that organification step. Okay? Most of you, the plurality of you got it right. Not most, the plurality got it right. So study that. All right. Trump 2020 got it right. That's good. That's fantastic. All right. Everyone's going to get me in trouble. My last day. Which is true. Oh. Yeah, so that's like your PowerPoint slides, what I was mentioning earlier about those different receptors. Study that one, okay? Try the next one. See, Trump 2020 got that wrong. All right. This was the test question. Which one? Which one represents how Michael looks in pink? Oh, good. Okay. That's what I was hoping. That's really what I was hoping. I made them all the right answer. I didn't want to like force you to say something, but I'm glad you said that. All right. All right. Look like a hot piece of man candy. All right. Oh, Jess got that one right too. And Trump 2020. Apparently, I don't know which one. All right. Couple people. All right. How many of you got it? Okay. All right. So, yeah. It's not low ACTH. So because it's a primary condition, remember the pituitary gland is still going to be secreting high levels of ACTH. So ACTH will be high in primary Addison's disease. So remember that, okay? You're right, they both have hyperpigmentation, but it's a high ACTH in primary. All right. Oogenesis. Which is true of oogenesis. Literally just did a flowchart about this. So let's see, like 5 minutes ago. I made a point to mention this exact thing. So let's see how this goes. Okay. Yeah, so I made a point to say that primary oocytes are surrounded by the zona pellucida. So they are surrounded by the zona pellucida. Circle got it right. So secondary oocytes are surrounded by multiple layers of cells. Remember I came out here and told you it's multiple layers of cells that surround the secondary oocyte? Okay. Oh, whatevs took the lead. Which of the following is true regarding female reproduction? Okay. Again, literally just talked about this, so let's see. Good. All right, most of you got it right. Remember I said FSH is high before ovulation, so in that follicular phase. All right, so most of you got it right. That was good. LH peaked right before ovulation. LH peaks right before ovulation, not after. Okay, that was the second highest answer. So it peaks right before ovulation. I made this kind of evil on purpose, okay? So, all right. J. Just J. Which of the following is true of glucagon? Okay. 39 of you got it right. Triangle was the second highest answer. So what's the issue with triangle? Which one of those is wrong? Right. So for those of you who guessed triangle, it's not glycogenesis, it's glycogenolysis. Okay? So remember, glucagon wants to break down glycogen into glucose, not build up more glycogen. Anybody have a question about that? Make sure you have that clear. If you have a question about it, yeah.
Can you repeat that?
Yeah. So glucagon wants to increase blood glucose levels. That means it wants to break down glycogen, or glycogenolysis, into its individual glucose parts and release it into the blood. Okay? Glycogenesis is the opposite. All right. Okay. Overall, not bad with that one. Demogorgon. Is that Stranger Things? Demogorgon? Do I have that right? What is that from? Something like that. All right. Diabetes mellitus type 1. Which is true of diabetes mellitus type 1. Type 1 diabetes. Good. Very good. All right. I'm happy about that. That's good. So you other 6 are slacking. I don't know where you other 6 are with that. No, so that's good. Remember, we said that it is it's an autoimmune disease, okay? But it is not a disorder that occurs during pregnancy. So that would be why diamond would be wrong. It isn't a disease that's passed down from parent to child, so it's not hereditary. And it's not a disorder of the receptor. Remember, it's a disorder of the actual cell that's secreting the insulin. Okay, so good job, guys. Secondary Cushing syndrome. A would be triangle, C would be circle. A would be triangle, C would be circle. Huh? Cushing syndrome, secondary Cushing syndrome, so that's secondary, so the disease is in the pituitary gland, right? See how this works out. This is what confuses probably the most people on these exams, is these primary to secondary disorders. Okay, most of you got it right. That's good. Yeah, so again, it would also have hypercortisolemia, so high cortisol in the blood. Okay, so Cushing syndrome secondary has high ACTH, and it also has high cortisol. Remember that? It's the increase of each of the 3 cortex hormones. Okay, so that's why it's both. Good. Good job. Just review that. That's on the slides. Good job, guys. Primary hyperthyroid. Just a few more people. All right. Okay. All right. I see where the issue was with square. Did you guys read like hyperparathyroidism instead? Yeah? Please don't make that happen on an exam. It's hyperthyroidism, so the parathyroid gland is not the thyroid gland. It's not the same thing. All right, you guys who guessed circle, good job. False regarding PTH. Yeah, false regarding PTH. False. They're not all going to say true on the exam, right? So you're going to have some fun. It's not mean. I did this for your own good. It's not mean. All right. Only 52 people, but most of you got it right. Okay, good. All right, I'm going to stop it here so we do clinical questions. Demogorgon wins. I'm Ugly came in second. So I'm Ugly is not a hot piece of man candy. Okay. Let's go back. Just 1 second. Okay. I'll try one more time, if not I'll show you on the doc cam. Okay. Hold on. All right. Can you guys see this? So read number 1 and tell me what you think the case would be. So we have a 35-year-old male who is physically fit, says he has lately been very thirsty and pissing like a racehorse. Physician tests his fasting glucose and HbA1c, which are glucose tests. Okay. They find that his blood glucose levels are normal. What is the most likely diagnosis? So this is one that we actually didn't go over in today's review, but let's see how many of you actually might know this one. You said diabetes insipidus? Why is it diabetes insipidus? Okay. Diabetes insipidus is a disease of low ADH, right? So low ADH will mean that you have low antidiuretic hormone. Low antidiuretic hormone means you're secreting too much water. So that's dehydration. That's why he's thirsty and peeing a lot. All right? We also have high urine and thirst in diabetes mellitus. So in diabetes mellitus because of the glucose concentration. But his glucose is normal here. So that's why it's not diabetes mellitus and it's diabetes insipidus. Okay? All right, let's try number 2. So 50-year-old man presents to his physician with headache, vomiting, nausea, sleep disorder, vision problem, vertigo, palpitation. He also has hyperglycemia, hypernatremia, hypokalemia, and claims to have an increased appetite and weight gain. If you guys, this is boss level. You know, like in video games when you get to like the boss level, like at the end of every, if you can do this one, you should be feeling pretty good. There's a dexamethasone test, which is an ACT analog, which means dexamethasone essentially is like, think of it as your body will recognize it as ACTH, but it won't necessarily serve all of the same function, but it'll recognize it as ACTH. And when he was given this dexamethasone test, his ACTH levels dropped. What is the proper diagnosis? Anybody have? You think it's primary Cushing's? Okay. Why would it be primary? Well, so first of all, let me just, I'm going to get right back to you, but just recognize the headache, vomiting, nausea, sleep disorder, all that stuff is indicative of what? That's hypertension, right? Okay. Why are you saying it's primary Cushing's? Okay, so that's telling you that it's definitely, I can see Cushing syndrome there. Hypercortisol, yeah, good. But how do you know it's primary Cushing's? Very good. So what she said was, when we gave dexamethasone, the body recognized it as ACTH and dropped the ACTH levels. So that's telling you that the pituitary gland is fine. It's receiving the signal. So then the problem has to be in the adrenal cortex. Does that make sense? The problem has to be in the adrenal cortex, so that's telling you it's primary Cushing syndrome. All right? So to make a complete diagnosis, not just Cushing's, but primary Cushing syndrome, so you know where the issue is. Okay? Any questions about that? So even if you had never heard of dexamethasone, you should be able to get a question like that to apply your knowledge. Okay? Any questions? Good? All right. Okay. 44-year-old female presents with hypotension, bradycardia, and lethargy. She has slight inflammation of the thyroid. Blood test reveals high levels of T3 and T4 and low levels of TSH. And low levels of TSH. It is also found that she has high levels of serum. Oh, I made a mistake. Hold on. Sorry. Wait a second. There we go. Sorry about that. So blood test reveals she has low levels of T3 and T4 and high levels of TSH. And it's found that she has high levels of serum proteins, possibly antibodies. Okay, what's the diagnosis? Okay, good. How'd you know Hashimoto's and not just like a generic? Very good. So we're looking at autoimmune hypothyroidism. So that's telling you Hashimoto's. That's the disorder that you know of. That's autoimmune hypothyroidism. Any questions about that one? Okay. Let's do 53, the 53-year-old male. So 53-year-old male presents with hypertension, anxiety, sweating, and palpitations. He has normal levels of sodium and potassium. T3, T4, and TSH are high, and he has unilateral thyroid swelling. Unilateral thyroid swelling means he has swelling of the thyroid in one spot. So one spot of his thyroid is swollen, which is normally a tumor instead of just generic inflammation. He has no history of illness other than abdominal cyst removal 1 year ago. Physician controls his thyroid hormone issue, but the palpitations, anxiety, and sweating persist. So even after we resolve the thyroid problem, he still has issues. What is the most likely diagnosis? This is another tough one. I made this purposely evil. What are disorders that we know of that can raise blood pressure? Hyperthyroidism, Cushing Syndrome, right? What's another one that we know of that can raise blood pressure? Another one dealing with the adrenal gland. Pheochromocytoma, okay? Pheochromocytoma is an increase in what? Okay, so we've got those three things essentially that we can look at, right? Those are the three that can raise our blood pressure. Well, we know that he had a thyroid problem, right? Because he had high levels of T3, T4, and TSH. But we took care of that. What else could be causing his problems? Yeah, so he might have multiple things, all right? It doesn't only have to be one thing. He could have multiple problems. Why would you say pheochromocytoma rather than Cushing syndrome? Okay, he has normal levels of sodium and potassium, which would not be the case in Cushing syndrome, right? He would have hypernatremia and hypokalemia. Also, I said he had abnormal cyst removal 1 year ago. If he has a history of cysts in his abdomen, pheochromocytoma is a cyst of the adrenal medulla, right? That's in your abdominal cavity. So that's increased risk for that. Does that make sense? Okay? You need to be able to put things together like that. That's the reason I made the question, so that you guys can kind of get some practice putting all kinds of things together. It's going to be messy, all right? It's going to be messy, but you got to think about it. All right. We'll do one more. Let's see. Let's do this one. 43-year-old male presented with hypotension, lethargy, and bradycardia. Okay? He had unilateral That's one-sided swelling of the thyroid gland. A partial thyroidectomy was performed. That means a partial removal of the thyroid gland was performed to remove the site of abnormal cell growth. 10 days after the operation, he had muscle spasms and a serum calcium level of 6 milligrams per deciliter. Is that normal? What's normal? 10 milligrams per deciliter, so this is low, right? What do you think happened? Think we took out the parathyroid gland? Took out, okay. So explain how taking out the parathyroid gland would result in these issues. What was that? Low calcium. So if, that's exactly right, very good. So be aware of the anatomy of this also. We took out the thyroid gland, so it's possible we took out the parathyroid gland as well, because that's right behind the thyroid. That means we're removing the possibility for parathyroid hormone, right? If we remove parathyroid hormone, we decrease blood calcium. All right, that's the idea behind that. Keep reviewing this stuff. It's all on the study union site, and there'll be these clinical questions up there as well. All right, these are going to be posted on there. I'm also going to post up the flow charts that I made today. Okay. To the practice test, I probably will because I made it especially hard. So the practice test that I made, I'll post the answers in there as well in the study union site because I made it sort of especially hard for you guys. So hopefully if you can do that, you'll feel good on the regular exam, hopefully. Huh? Yeah, I can, oh, to the last one? I can post them in the site, yeah. All right. Yeah? Study union site? Yeah, definitely, yeah. Yeah. Anybody who filled out those surveys, all right, just like pass them to one side of the table, just so that I can pick them up, yeah. What?
Up there. Which numbers do you need to put?
Provided by the facilitator? I'm not really sure. By the way, guys, thank you all for coming, and especially thank you all to those who came to my sessions really frequently. All right, I really appreciate it. This was my last semester tutoring human physiology, so I had a really good group this time. I'm going to miss it, but thank you guys for coming in. I really appreciate it, all right? Thanks. Oh, yeah.